So thank you all for joining us for the next 2 hours. We are going to be going over the 2019 CMS program-specific measure needs and priorities, and this is the fourth, so the last of our webinars to kind of kick off the 2019 pre-rulemaking cycle. So for the presentation, just to minimize all of the background noise and everything, all of our lines are going to be muted during the presentation, and we will be recording this so that way you can view it in the future or share it with colleagues, etc., that were unable to attend. That recording should be on the website in the next 2 or 3 weeks, but we'll put the slides in there in a shorter time frame than that. We will pause at each, we have 3 segments. We're going to pause and open the lines for questions during that segment. But in order to not forget your question or just, to have increased ease, please feel free to submit your questions via the question function through WebEx. That would be kind of easiest and make sure that we're going to go through those first. So we're going to start off with a brief, and I promise to keep it brief because I'm sure most, if not all of you, know about Meaningful Measures and our initiative. I'm going to do a brief Meaningful Measures initiative overview and then a brief overview of the pre-rulemaking cycle and where we are. And then we're going to go through each of the 18 programs. It's categorized into 3 segments, chronic and post-acute care, clinician and hospital. We're going to go through each of those segments, and the programs are going to speak to their individual needs and priorities. And like I said, we're going to pause after each segment and open the lines up for questions and go through the questions that have come through WebEx. So I'll pause here and just quickly introduce myself. So my name is Kim Rawlings, and I am with CMS. I'm the lead in the core for the measures management system, as well as the kind of co-coordinator with Helen Dollar-Maples for the pre-rulemaking cycle. So again, just to kick this off, I want to bring some awareness to the meaningful measures, since that's what we use to categorize and communicate our needs and priorities. So hopefully you've heard of it, but the Meaningful Measures Initiative was launched around November of 2017, and it was really meant to improve the outcomes for patients and reduce data reporting burden and cost to clinicians as well as other healthcare providers. But most importantly, and those are both important, but I think it really is about focusing our efforts to better align with what is most meaningful to the patient. And as we're going to talk about today, all of the programs are going to talk about, Meaningful Measures is also a way to identify where the gaps are in our programs and communicate those most efficiently to you, so that we're giving you very kind of clear guidance and clear communications around where we're focusing our quality measure efforts. Here are 4 CMS strategic goals, and they are really at the root of Meaningful Measures. It's about empowering patients and doctors to make decisions about their care and making sure that the measures that we put forth are what's most important to them. It's also about creating flexibility and leadership in our states and local governments. Supporting innovative approaches to improve quality, accessibility, and affordability. This is a clear tie-in with Meaningful Measures. It's not just about, Meaningful Measures is about improving quality by making sure that we're all kind of going in the same direction with our measures, but it's also about bringing innovation to the measure development process. And lastly, improving the CMS customer experience. And again, we think that we're improving that through Meaningful Measures by communicating most effectively. So Meaningful Measures is about the framework that we're going to see in a couple of slides, but it's also about these more broad objectives. And like I said, making sure that we not only as an agency and the measures that we develop ourselves, but that we're communicating with the broader industry and with other payers, and again, making sure that we're all going in the same direction and having some of the same objectives with the measures that we're developing. And so when we develop measures, we want to make sure that we're addressing high-impact measure areas, that we are making sure that measures are patient-centered, that we are keeping the clinician and providers and the patients all at the center of our thinking as we're working through that measure and how is it going to impact them. You know, there's definitely a place for process measures, but wherever possible, we want to try and have outcome-based measures. There are measures that we need to fulfill program statutes, and I think kind of where meaningful measures originated, and I brought up this a little bit before, but where meaningful measures originated was really decreasing burden. And of course, like I said, it's kind of morphed and grown and evolved a bit since then, but in the beginning, it was reducing burden was definitely at its core. And then there are a couple of others, like, you know, aligning across programs, making sure that we're addressing measure needs for population-based payment, and making sure that there's significant opportunity for improvement. Next, like I said, the ultimate goal here is that we are making sure that we're increasing the quality of health care and having the most meaningful outcomes for patients. We did not develop meaningful measures in a silo. We used and drew from lots of work from LAN and QF, the National Academy of Medicine, etc., and, you know, got different perspectives from experts, both internal and external to the government. Excuse me. And this is the framework that everyone should be very familiar with. At the center, we have our 4 strategic goals. In the words kind of around, we have our cross-cutting criteria, like eliminating disparity, achieving cost savings, track to measurable outcomes and impact, and those are things that all of our measures should meet. Then on the list there, in the large bold letters, we have our 6 healthcare priorities, like make care affordable and strengthen person and family engagement as partners in their care. And then the bullet points beneath, we have our meaningful measure areas. And those are 19 areas that, again, are supposed to kind of be the connectors in describing our areas of focus, because we recognize that the healthcare priorities are very broad. And so we wanted to get a little bit more specific, and so that's how we developed the meaningful measure areas. And then the next slide, we'll just walk through one very quick example. So here we have the healthcare priority, promote effective prevention and treatment of chronic disease, and there are 5 meaningful measure areas underneath of this. Preventive care, management of chronic conditions, prevention, treatment, management of mental health, prevention, treatment of opioid and substance use disorders, and the 5th and final category, risk-adjusted mortality. And so on this slide, you can see there are several measures, and these are just example measures. There are more preventive care measures in our programs, but you can just see, you know, timeliness of prenatal care is an example of a preventive care measure, and that measure is used in Medicaid and CHIP. And if you go, next slide, if you go onto our website, you can learn a lot more about those categories. And if you go on to CMIT, the CMS Measures Inventory tool, you can view many of our measures that are actively in our programs. You can see where we've assigned them to the meaningful measures area. So again, when you submit measures into JIRA, you're going to have to assign a meaningful measure area and a healthcare priority to your measure, but you'll hear, as the programs are speaking, you will hear these meaningful measure areas and hear them talk about the healthcare priorities. Next. So just to talk a little bit about pre-rulemaking really quickly. Pre-rulemaking is mandated by Section 3014 of the Patient Protection and Affordable Care Act, and there are 3 main steps and kind of milestones in the process. By December 1st, we have to publish the measures under consideration list. We then hand that to our multi-stakeholder group, the Measures Application Partnership, which is currently held through the National Quality Forum. And then by February 1st, the MAP provides recommendations and feedback on the MUC list to the HHS Secretary. And so in order to meet those timelines and meet those deadlines, we need to have measures submitted by June 3rd. That is the magic date for 2019. And the needs and priorities document, and as people are going through and talking about their program, they may go over some of the more program-specific measure requirements, but in general, for all programs, it's important that the measures be feasible to implement and be fully developed and tested for reliability and validity. We need to make sure that we are being sensitive to the program goals and statutory requirements, and that's what today is supposed to help you with. And, you know, today also helping with identifying the important conditions and topics for performance gaps. We want to make sure that all of the measures aligns with CMS programs, and as possible, making sure they align across HHS and private payers as well. We definitely seek to do that with our measures and our programs to decrease burden and, again, just increase alignment. We want to make sure that the measures are not, quote-unquote, topped out, that there is room for improvement within that area of quality that the measure is focusing on. We want to make sure there aren't any duplicates and we don't have any similar measures already in our programs. For ECQMs especially, but for all measures, feasibility testing is especially important. And then, like I said, all the measures submitted to the MUC list should be fully developed, and so it should have a title, numerator, denominator, exclusions. The measure steward should be clear. There should be a link to full specs, and there should be an established mechanism for data collection. You should have, if you haven't already, started to get an account through JIRA. You can email mmssupport@battelle.org to help you with that. And once the measures have been submitted through JIRA, we review them in real time, so it's better to submit your measures earlier in the process. But we review them real time, and then they start to go through our clearance process and get reviewed by leadership, first at CMS, then HHS, etc. And if you go to the pre-rulemaking website, all of that information is laid out in great detail to help support your submission. So with that, I want us to go ahead and get started talking about the needs and priorities for our 18 programs for the 2019 kind of pre-rulemaking cycle. Right now, we unfortunately do not have the document that accompanies this. However, I promise it should be posted online within the next 3 or 4 weeks. And because you've logged on to the webinar today, we will take all of those emails and logins, and we aren't going to bombard you, but we'll send you a quick email once the document has been posted so you have it as your reference. We will be kind of switching between the slides today that will outline the programs that will be speaking and the actual the draft needs and priorities document that we have, so that you can get a sneak peek, but unfortunately we're unable to distribute it quite yet at this time. But if you have any burning questions, please feel free to ask today, and we will do our best to help. So with that, we can go to the next slide. We're going to have our programs that relate to chronic and post-acute care go first. And so if Katie Brooks could get us started with the Inpatient Rehabilitation Facility Quality Reporting Program.
Hey, Kim. Thank you so much. Good afternoon, everybody. My name is Katie Brooks, and I'm briefly going to be discussing the Inpatient Rehabilitation Facility Quality Program, also known as the QRP. This program was established in 2012, and it's continued its development with response to the Impact Act of 2014. Under the authority of the Impact Act, the IRF-QRP collects and publishes data on quality measures, and IRFs that fail to submit the required data to CMS will have their annual increase factors reduced by 2 percentage points for the upcoming fiscal year. So we currently have 15 previously finalized and adopted measures that fall into 3 categories. We have our Centers for Disease Control and Prevention, National Health Safety Network measures, also known as our CDC NHSN measures. We have claims-based measures, and then we have measures that come from our Inpatient Rehab Facility Patient Assessment Instrument, also known as the IRF-PI. We have those assessment-based measures as well. As you can see on the table displayed through the WebEx, our current measures that are prioritized under the healthcare priorities and meaningful measures are listed. We currently have 1 measure in the healthcare priority area of effective prevention and treatment, 4 measures in making care safer, 3 measures in communication and care coordination, 1 measure in best practice of healthy living, 1 measure in making care affordable, and 5 measures in patient and family engagement. And then CMS has identified the exchange of electronic health information interoperability measure concept as a high priority for the IRF-QRP future reconsideration. CMS believes that successful health information exchange supports several critical healthcare goals by promoting high-quality, personalized, and efficient healthcare, care coordination and person-centered care, real-time, data-driven clinical decision-making, and finally, the ability for patients to fully participate in their healthcare. So thank you so much. That's everything I have for IRF. At this time, I'd like to turn it over to my colleague, Carol Schwartz, for the Ltac Quality Reporting Program.
Hello. Thank you, Katie. My name is Carol Schwartz, and I'll briefly be discussing the Long-Term Care Hospital Quality Reporting Program, or Ltac-QRP. The program was established in 2012 and has continued in its development with response to the Impact Act of 2014. There are currently 15 measures adopted for the Ltac-QRP, the majority of which are required by statute. Similar to the IRF program, the finalized measures fall into 3 categories. Those supplied by the Centers for Disease Control with their National Healthcare Safety Network measures data, claims-based measures, which are based on fee-for-service, and assessment-based measures using the data collected from the Ltac Care data set. This table details the Ltac-QRP measures with respect to the healthcare priority and meaningful measure areas they address. As you can see from the table, 3 measures are effective prevention and treatment, 5 measures are in making care safer, 2 measures are in communication and care coordination, 1 measure is in best practice of healthy living, 1 measure is in making care affordable, and 3 measures are in the patient and family engagement area. CMS has identified the following 2 high-priority meaningful measure areas for Ltac-QRP future measure consideration. The first is patient and family engagement functional outcomes. While rehabilitation and restoring functional status are not the primary goals of patient care in the Ltac setting, functional outcomes remain an important indicator of Ltac quality, as well as key to Ltac care trajectories. The second is exchange of electronic health information and interoperability. CMS believes that the ability to exchange healthcare information supports the goal of high-quality care for Ltac providers. Thank you, and I will now turn it over to Stephanie Felder for the Home Health and Hospice Quality Reporting Program.
Thanks, Carol. My name is Stephanie Felder, and I am the Measure Analyst for the Home Health Quality Reporting Program and the Hospice Quality Reporting Program. First, I will present on the HHQRP. The Home Health Quality Reporting Program, HHQRP, was established in accordance with Section 1895B of the Social Security Act. Home health agencies are required by the Act to submit quality data for use in evaluating quality for home health agencies. Section 1895B of the Act also requires that HHAs that do not submit quality data to the Secretary be subject to a 2% reduction in the annual payment update, effective in calendar year 2007 and every subsequent year. Data sources for the HHQRP include the Outcome and Assessment Information Set, OASIS, Consumer Assessment of Healthcare Providers and Systems, CAPS, and Medicare FFS claims. As in the IRF, Ltac, and SNF quality reporting programs, the IMPACT Act has expanded the Home Health Quality Reporting Program to report standardized assessment data and data on quality measures, including resource use measures. The HHQRP measures that have currently been prioritized under the National Quality Strategy are listed on the home health slide provided for this presentation. As you can see on the table, currently HHAs have one measure in the effective prevention and treatment, 2 measures in making care safer, 7 measures in communication care coordination, 1 measure in healthy living, 1 measure in making care affordable, 7 measures in patient and family engagement. High priority domains for future measure consideration in the HHQRP are, number 1, patient and family engagement. Care is personalized and aligned with patients' goals. Functional status and preventing functional decline are important priorities to assess for home health patients. Patients who receive home health care may have functional limitations, individual functional goals, and may be at risk for further decline in function due to limited mobility and ambulation. Number 2, communication and care coordination. Admissions and readmissions to hospitals assessing patient hospitalizations are important. Therefore, CMS is considering developing measures that assess discharge to the community and potentially preventable hospitalizations. Number 3, exchange of electronic health information and interoperability measure concept. CMS believes that home health provider health information exchange supports the goals of high quality, personalized, and efficient health care, care coordination, and person-centered care, and supports real-time, data-driven clinical decision-making. The interoperability of health information across healthcare systems is key to achieving safe, efficient, and high-quality health care. It is also necessary for home health patients and residents to fully participate in their health care. Now I will present on the Hospice Quality Reporting Program. The Hospice Quality Reporting Program was established in accordance with Section 1814I of the Social Security Act, amended by Section 3004C of the Affordable Care Act. The HQRP applies to all hospices regardless of setting. Beginning in FY 2014, hospices that fail to submit quality data will be subject to a 2% point reduction to their annual payment update. In August 2017, the Hospice Compare website went live. Hospices are currently reporting on 10 measures collected through the Hospice Item Set and the Consumer Assessment of Healthcare Providers and Systems, CAPS. The HQRP measures that have currently been prioritized under the National Quality Strategy are listed on the hospice slide provided for this presentation. As you can see on the table, currently hospices have 1 measure in the communication care coordination and 9 measures in the patient and family engagement. High priority meaningful measure areas for future measure consideration in the HQRP are communications care coordination. CMS is working to convert the hospice visits when death is imminent measure into a claims-based version. This current measure is a measure pair comprised of complementary but independent measures assessing hospice staff visits to patients at the end of life. Measure 1 examines percentage of patients receiving at least 1 visit from registered nurses, physicians, nurse practitioners, or physician assistants in the last 3 days of life. Measure 2 examines percentage of patients receiving at least 2 visits from medical social workers, chaplains, or spiritual counselors, licensed practical nurses, or hospice aides in the last 7 days of life. Where possible, the new hospice visits when death is imminent measure will be aligned with the Services Intensity Add-on SIA policy and will focus on services provided by the RN and medical social worker services at the end of life. I will now turn it over to Casey to present on the Skilled Nursing Facility Quality Reporting Program.
Thanks, Jeff. Good afternoon, everyone. My name is Casey Freeman, and I'll briefly be discussing the Skilled Nursing Facility Quality Reporting Program, or the SNF-QRP. This program was established in fiscal year 2018 in response to the IMPACT Act of 2014. The Impact Act provides the authority to require and collect data. Providers that fail to submit the required quality data to CMS will have their annual payment updates reduced by 2 percentage points. The SNF-QRP currently has 11 adopted measures which fall into 2 categories: claims-based measures, which use data from the fee-for-service claims, and assessment-based measures, which use data from the MDS or 3.0 minimum data set. The table on the screen summarizes our 11 current measures with respect to the healthcare priority and meaningful measure areas they address. As you can see from this table, the SNF-QRP has measures addressing the following healthcare priorities: 2 measures in making care safer, 2 measures in communication, care coordination, 1 measure in best practice of healthy living, 1 measure in making care affordable, and 5 measures in patient and family engagement. CMS has identified the following 2 high-priority meaningful measure areas for future measure consideration within the SNF-QRP. The first is making care safer, healthcare-associated infections. Healthcare-associated infections are an important public health and patient safety issue. These infections are one of the most common adverse events in healthcare and are associated with longer episodes of care, higher intensity care, and increased mortality. Addressing healthcare-associated infections in SNFs is particularly important for our residents because they are at high risk for developing infections due to their increased age, cognitive functional decline, and use of indwelling devices, frequent care transitions, and close contact with other residents and healthcare workers. The second meaningful measure area for future measure consideration is exchange of electronic healthcare information and interoperability. CMS believes that the ability to exchange healthcare information supports the goal of high quality of care and for SNF providers, and our program cites the same rationale described by the IRF QRP to support this measure concept. And now I would like to turn things back over to my colleagues who are hosting this event.
Thank you all so much for the overviews on your programs. I think I'm going to check in with Battelle and see if there are any questions that have come in through the chat, the question function.
Yeah, this is Vince Brown from Battelle. Thank you, Kim. We did have 2 questions come in so far online. One says, can we use the same JIRA account through ONC that we would use for QCDR or some other JIRA project? The answer is yes, you use the same ONC account, but you do need to request to be added to the user set for measures under consideration for 2019. CMS likes to keep track of who's using the JIRA database, and also we capture the name and the email for future announcements and communications in subsequent years. So you do use the same ONC account, but you need to, if you are new and have never used it for measures under consideration, you do need to request through MMS support. There's an email in our user guide on the pre-rulemaking website, and you would request on that for access to the particular 2019 MUC list project. The second question is, does CMS have any guidance for how to select the secondary priority and the secondary meaningful measure areas that were announced on the kickoff webinar last week? Kim, I don't know if you have any guidance on that that you would like to add at this time.
Sure. So the secondary meaningful measure area is, first off, it's optional, so you do not have to fill it out. And it's really there for your convenience. There are some measures that, you know, people feel like they just really fit into 2 programs perfectly, and so they have a kind of a hard time making that determination of, you know, is it medication management or is it treatment and prevention of opioid and substance use? And so we gave that opportunity to, or gave that option to put in a second meaningful measure area if you were having trouble determining which one it fit into. And then, you know, us on the CMS end, you know, there's only, for example, there's only going to be 1 meaningful measure area in CMIT when we put the MUC list through, you know, when we add the MUC list, the 2019 MUC list to CMIT, we're only going to choose that first one probably, but it just gives CMS some additional information in case you felt very strongly that there was another area that it fell into. But again, completely optional. We're really concerned about the primary.
Kim, those are the only questions that I have seen, unless Marissa might have seen others. That's all that I've seen from the chat or Q&A function on WebEx.
Okay, if we want to open the lines very quickly and if you please go on mute if you are not actively speaking. If we get way too much background noise, then we're only going to be able to take questions through the Q&A feature on WebEx. So does anyone have any questions for us? Going once? Going twice? All right. Well, I want to thank our first segment so much. Thank you for presenting. And we're going to move on to our next segment, which is our programs involving clinicians. And we're going to start off with Susan Arday with the MIPS program.
Hi, good afternoon. This is Susan Arday, and I'd like to go over briefly about the merit-based incentive payment system and measurement for this year and our needs and priorities. As you know, the Medicare Access and CHIP Reauthorization Act of 2015, MACRA, ended the SGR formula, and that's what ultimately ended up creating the quality payment program, which has two participant pathways. One is the merit-based incentive payment system, MIPS, and the other is advanced alternative payment models, or advanced APMs. So the MIPS, as you know, combines three Medicare legacy programs: the Physician Quality Reporting System, Value-Based Payment Modifier, and the Medicare EHR Incentive Program for eligible professionals, and puts them into a single program. And under MIPS, there's 4 connected performance categories that will affect the clinician's future Medicare payments. Each performance category is scored independently and has a specific weight indicating its contribution toward the MIPS final score. The MIPS performance categories and their 2019 weights toward the final score are: quality is 45%, promoting interoperability is 25%, improvement activities is 15%, and cost is 15%. Final score, 100%, will be the basis for the MIPS payment adjustment assessed for MIPS eligible clinicians. So to implement new quality measures into the performance category of MIPS, CMS uses the annual call for measures, and that lets clinicians and organizations, including those not limited to those representing MIPS eligible clinicians, such as professional associations and medical societies and other stakeholders, such as like researchers and consumer groups, submit quality measures for consideration. The recommended list of new quality measures will be publicly available for comment through the rulemaking process before making a final selection for new quality measures. The list will not include qualified clinical data registry measures, QCDR measures, as those measures are proposed and selected through a separate process. The quality performance category focuses on measures in the following quality priorities and meaningful measure areas for future measure thought and selection. And I believe on the screen here, yes, we've got a table that details the number of quality measures in each meaningful measure area currently implemented in the MIPS program. And what you'll see here in this table is we've got a lot of measures that are under the effective prevention and treatment MMA area, 115. The next largest area under that is, let's go down a little bit here, the communication and coordination of care area, followed closely by the making care affordable area. The area where we have the least, actually no measures right now, is best practices for healthy living, including equity of care and community engagement. So what are our high priority meaningful measure areas for future measure consideration? Well, CMS will not propose the implementation of measures that do not meet the MIPS measure set gaps or criteria of performance. And the gap areas include, but are not limited to, orthopedic surgery, parentheses, hand surgery, pathology, ophthalmology, radiology, chiropractic medicine, mental health and substance use conditions, oncology, palliative care, and emergency medicine. MIPS has a priority focus on outcome measures, measures that fill a topped-out specialty area, and measures that are relevant for specialty providers. CMS has identified outcomes and opioid-specific measures as high priority for future measure consideration. Outcome measures show how a healthcare service or intervention influences the health status of patients. So, for example, the percentage of patients undergoing isolated CABG surgery who require postoperative intubation greater than 24 hours, the rate of surgical complication, or the rate of hospital-acquired infections. CMS identifies the following as high priority for future measure consideration under MIPS. One is person and caregiver-centered experience and outcomes. That means that the measure should address the experience of each person and their family and the extent to which they're engaged as partners in their care. And CMS specifically wants to focus on patient-reported outcome measures, PROMs. Person or family-reported experiences of being engaged as active members of the healthcare team and in collaborative partnerships with providers and provider organizations. Our second area is communication and care coordination. This means that the measure must address the promotion of effective communication and coordination of care and coordination of care and treatment with other providers. Our third area is efficiency/cost reduction. What that means is the measure must address the affordability of healthcare, including unnecessary health services, inefficiencies in healthcare delivery, high prices, or fraud. Measures should cause change in efficiency and reward value over volume. 4, patient safety is a big area for us. That means that the measure must address either an explicit structure or a process intended to make care safer, or the outcome of the presence or absence of such a structure or process. It could also be harm caused in the delivery of care. And what that means is that the structure, process, or outcome must occur as part of or as a result of the delivery of care. And finally, we also have appropriate use. And CMS wants to specifically focus on appropriate use measures. And what that means is that the measure must address appropriate use of services, including measures of overuse. So, the question we get a lot is the identification of topped-out measures, and that can lead to potential measure gaps. A measure may be considered topped out if measure performance is so high and unvarying that the meaningful distinctions and improvement in performance can no longer be made. Topped-out process measures are those with a median performance rate of 95% or higher, while non-process measures are considered topped out if the truncated coefficient of the variation is less than 0.1 and the 75th and 90th percentiles are within 2 standard errors of each other. CMS continues to identify topped-out measures throughout the benchmark file. And let me see if you've got this. Yes, you can see there are 59 quality measures that have been labeled as measures in the 29 topped-out measures status. And these 59 quality measures will activate the special topped-out scoring policy beginning with the MIPS 2019 performance period. Scrolling down, it's a fairly long list. And as the topped-out measures are removed from the program, CMS will monitor the impact of these removals on the quality measure specialty sets that are available for clinician reporting. CMS strongly encourages measure developers to review the benchmark file that identifies topped-out measures and develop measures that may replace those topped-out measures for future program years. In addition, CMS also very much welcomes stakeholder suggestions to address these potential gaps within the measure sets. And if you go to our cms.gov website, under QPP, you can find the 2019 quality benchmark file from December 27th of 2018, posted right out there for you to take a look at. So, okay. There's a couple measure requirements. I'll just go over these real quick. CMS applies criteria for measures that may be considered for potential inclusion in the MIPS. At a minimum, the following criteria and requirements must be met for selection in the MIPS. So first of all, CMS is statutorily required to select measures that reflect consensus among affected parties and, to the extent feasible, include measures set forth by one or more national consensus-building entities. So to the extent practicable, quality measures selected for inclusion on the final list will address at least one of the following quality domains: effective prevention and treatment, making care safer, communication and coordination of care, best practices of healthy living, making care affordable, or person and family engagement. In addition, before including a new measure in MIPS, CMS is required to submit for publication in an applicable, specialty-appropriate, peer-reviewed journal the measure and the method for developing the measure, including clinical and other data supporting the measure. The measures implemented in MIPS could be used for public reporting on physician compare. The measures must be fully developed with completed testing results at the clinician level and ready for implementation at the time of submission. Preference will be given to measures that are endorsed by the National Quality Forum, NQF. Measures should not duplicate other measures currently in the MIPS. Duplicative measures are assessed to see which would be the better measure for the MIPS measure set. Measure performance and evidence should identify opportunities for improvement. CMS does not intend to implement measures in which evidence identifies high levels of performance with little variation or opportunity for improvement. In other words, measures, as I mentioned earlier, that are topped out. MACRA, Section 101C1, requires submission of the new measures, as I mentioned, for publication in the applicable specialty appropriate peer-reviewed journal. The peer-reviewed journal template provided by CMS must accompany each measure submission. And if you look at the template, you'll see that what your additional information is you need there. Furthermore, electronic clinical quality measures must meet electronic health record system infrastructure requirements as defined by the MIPS regulation. Now, beginning in calendar year 2019, eCQMs will use clinical quality language as the expression logic used in the health quality measure format, HQMF. CQL has replaced the logic expressions currently defined in the quality data model. The data collection mechanism must be able to transmit and receive requirements as identified in MIPS regulation. So, for example, eCQMs being submitted as quality reporting data architecture, QRDA3, must meet QRDA3 standards as defined in the CMS QRDA3 implementation guide. eCQMs must have HQMF output from the measure of authoring tool, MAT, using MAT version 5.6 or more recent, with the implementation of the clinical quality language logic. And you can find additional information on the MAT out on the ecqi.healthit.gov website. Bonnie test cases must accompany each eCQM submission. Additional information on eCQM tools and resources can again be found out on that ecqi.healthit.gov website. Feasibility, reliability, and validity testing must be conducted for eCQMs, and your testing data must accompany submission. So, for example, if a measure is being reported as a clinical quality measure, a CQM, or what we might call as a registry measure, and an eCQM, testing data for both versions of those measures must be submitted. We have some criteria on eCQM readiness. I will not go over those in the interest of time, but you can see them here displayed on the screen. In short, you need to assess and document your eCQM characteristics. Is your eCQM feasible? Is the eCQM a valid measure of quality and or the data elements in the eCQM valid? Is the eCQM reliable? We also need you to assess and document your eCQM specifications readiness. So, is your eCQM specified according to CMS and ALC standards? We need you to create value sets that use current standardized terminologies. We really mean it when we say this needs to be ready to roll. And finally, you need to give us your test eCQM logic using a set of test cases that cover all branches of the logic with 100%, repeat, 100% pass rate in Bonnie. There are resources you can refer to for assistance and work with this. There's the Value Set Authority Center on the NIH NLM's website, the Bonnie site on the healthit.gov website, the ECQI Resource Center that I've referred to a couple times already here. And also, go to the CMS Measures Management System Blueprint. We just recently posted an updated version of it out there, and that is extremely useful when you are submitting measures for the MIPS quality, whether they be CQMs or ECQMs. Now I'd like to pass the baton to Fiona Larby.
My name is Fiona Larby, and I'm the Quality Lead for the Medicare Shared Savings Program. The Medicare Shared Savings Program was designed to facilitate coordination and cooperation among providers to improve the quality of care for Medicare fee-for-service beneficiaries and reduce the rate of growth in healthcare costs. Eligible providers, hospitals, and suppliers may voluntarily participate in the Shared Savings Program by creating or participating in an Accountable Care Organization, or an ACO. If ACOs meet program requirements and the ACO Quality Performance Standard, they are eligible to share in savings if earned. In December of 2018, CMS released the Medicare Shared Savings Program Accountable Care Organization's Pathway to Success Final Rule. New policies in this rule included redesigning the participation options available under the program to encourage ACOs to transition to two-sided models in which they may share in savings and are accountable for repaying shared losses, providing new tools to support coordination of care across settings and strengthen beneficiary engagement, ensuring rigorous benchmarking, promoting interoperable electronic health record technology among ACOs, providers, and suppliers, and improving information sharing on opioid use to combat opioid addiction. Currently, there are 23 measures in the Shared Savings Program measure set. These measures are reported by the ACO via the CMS web interface, claims-based measures that are calculated by CMS, and caps for ACO survey measures. These 23 measures fall into the following meaningful measures areas, which are shown on the screen. 9 measures in the effective prevention and treatment category, 1 measure in making care safer, 3 measures in communication and care coordination, and 10 measures in patient and family engagement. Our high priority quality measure areas for future consideration include measures addressing high priority healthcare issues such as opioid use, outcome measures that address conditions that are high cost and affect a high volume of Medicare patients, measures that are targeted to the needs and gaps in the Medicare fee-for-service patients and their caregivers, measures that align with CMS quality reporting initiatives, such as the Quality Payment Program, and measures that support improved individual and population health. And now I'll pass it back to Kim. Thank you.
Thank you so much, Fiona and Susan, for those summaries. Now I'm just going to check in with Vince and see if we have any questions through our Q&A through WebEx.
Yes, this is Vince Brown. We did receive a couple questions on the chat. One said, would any MIDS Prime be able to access JIRA, or is it program specific? The answer is anyone with an ONC JIRA account can access the MUC list as long, again, as you apply for to be put on the user access list for the 2019 MUC list. It's intended to promote transparency as these candidate measures come in and go through the comment and accept or reject process. And so anyone can look at any of the measures as long as you have access to that particular MUC list project. You don't have to be a contractor. It could be a measure owner, a measure steward, or any other stakeholder. The other question, and Kim, you may have a comment on this. This is referring to an earlier webinar last week when it was said that measures must be fully tested or NQS ready before they go on the MUC list. And a caller asked, how does that fit with the question in JIRA about state of development? You can choose early development or field testing status as opposed to fully developed. Can you elaborate on the development or the testing requirement?
Sure, thanks. So just to clarify, yes, the measures do need to be fully developed and fully tested prior to going on the MUC list. We kind of use that question a little bit to kind of test the waters and, you know, see where people kind of rank their own measure versus, you know, how we would categorize that measure. So we use it as kind of a, we look at every single measure, but that question helps us gauge whether the measure is ready to be on the MUC list or not.
Okay, I am not seeing any other questions coming in through the Q&A or chat right at this time. Let me double check.
Okay, we go ahead.
Here's one. Oh. Here's a new one, Kim. It says, does implementation in a registry count as testing?
So, testing in a registry would not count as being fully tested, as it's such a small and limited kind of pool versus, you know, our measures going into a national program and being more widely tested. I'll see if any of my colleagues have anything to add.
Yeah, I mean, correct me if I'm wrong, Susan, but, you know, we give preference to measures that, if they're not NQF endorsed or endorsement ready, meaning that they meet the basic testing standards for, you know, potential submission to the National Quality Forum. Not that we mandate submission, but that they have to have kind of reached those standards. And I think some registry measures have, but others probably have not. So I would suggest looking at the testing requirements, you know, for that endorsement in order to determine whether the registry's testing is sufficient.
Yeah, and you can use the blueprint as a reference as well. I think it's either Chapter 21 or 22 that's on testing, you know, and it really walks through, you know, what is beta testing, alpha testing, beta testing, you know, feasibility testing, and really goes into some of the ins and outs of reliability and validity. And that's really what we're looking for here, is making sure that the measure is you know, meets those standards of reliability, validity, and feasibility, especially when we think about ECQMs. And of course, if you have any kind of further questions, you know, you can feel free to either elaborate on your question or follow up through MMS support. But we are looking to see that testing data. And when you get not just us and reviewing and putting on the MUC list, but when you get to the stage, if you were accepted on the MUC list, when you get to the stage of having your measure reviewed by the MAP, you know, they want to see that testing data. They're going to ask questions about, has this been tested? Is it valid? Is it reliable? You know, all of those are things that come up in the conversation with the MAP work groups. And so that's, you know, that's what they're looking for when they kind of make recommendations to the HHS Secretary of, yes, this measure is ready to be considered into a program.
There is a follow-up from that same questioner who said, if the registry were 12,000 participants and is a national scale registry, would that affect the answer?
No, I don't. You know, again, it's not just about scale. You know, I think that definitely can help, but it's not just about scale. It's really about the active kind of testing of that measure. And so, like I said, you know, there are lots of resources on the Measures Management System website around testing. If you want to, you know, kind of click through a PowerPoint or, you know, read a one-pager or something like that, our resources page on the website is very extensive. And, you know, that might help you get a little bit of an idea of what we mean by fully tested. And then, like I said, the blueprint's another resource. And please, I, you know, encourage you very much to, you know, reach out via email to MMS support, and we can communicate there back and forth to give additional guidance if you still have questions after reviewing some of those resources. But great question, thank you.
Okay, I'm not seeing any other questions coming in from the online chat or Q&A functions.
Yeah.
Great. I think we can open up the lines and quickly and see if there are any questions. Again, if you aren't actively asking a question, please go on mute so we do not hear any background noise.
I'm from the American Academy of Ophthalmology, and I was the one who put in the chat.
Yep.
I was the one that asked the question in the chat about testing, and I guess I just was looking for a little clarification on why implementation of a measure in a registry would not count as testing for reliability and validity. So specifically, I'm referring to QCDR measures that have been approved, that we have been using for several years in our registry, and we have implemented them across all of our registry participants that are electronically participating using an EHR. So the data is all derived directly from the EHR, and there's no manual entry of data included. And so I was just wondering why actual performance data wouldn't be able to count as reliability and validity testing results, since it's clear that the measure is acceptable to CMS because it is included in the QCDR measure set, and that we do have performance results, and we haven't identified anything wrong with the measure, like any outliers. We've been able to demonstrate reliability and validity of the measure by incorporating it into the specialty registry.
Thank you for that clarification. So, like I said, I don't, it sounds like that you've already done some testing if you've proven reliability and validity. So, again, without looking at all of your data and, having seen the measure kind of in JIRA and all the things that you will use to support it, I can't make a determination on the phone, but, so that's why I don't want to just say yes. But it very well could be that you have enough testing data, given everything that you've done to go through the MUC list. But again, you would need to submit to determine that. And I think I heard, it was a little difficult to hear you, but I think I heard that you have an ECQM, and in which case, the testing data through ECQM for ECQMs are very specific. We ask that you submit the MAT output and all of that. And I believe that all of that is outlined in the pre-rulemaking, on the pre-rulemaking website. And, we ask for very specific outputs and attachments, especially for ECQMs, in the JIRA guide. So you would have to submit that through JIRA. So, So yeah, like I said, for ECQMs especially, there are very specific things that you need to submit, the MAT output being one of them. So again, I would encourage, I'm not saying a yes or a no, but I would definitely encourage you to look at the pre-rulemaking website as well. And then if you have more questions, consult either us or consult the MMS website to maybe fill in some of the gaps there. But yeah, I would definitely go in. We have the JIRA template of what you would fill out in JIRA, and look through that, and see if you can meet those. See if you can fill in all of those fields and submit all of those attachments. Do we have any other questions from the phone lines, or did we get any more in the Q&A?
Nothing else online, Kim.
All right. Then thank you all so much. With that, I think we will move on to segment 3. It's our longest segment, so please, again, so you don't forget your questions, and because it can be difficult to hear on the phone, please feel free to put your questions in the Q&A. I think we have around 10 programs, so again, I don't want you to forget your question if it's on, HRRP or something that's earlier on. So let's go ahead and start with the Hospital-Acquired Condition Reduction Program, and Anise Abdullah McLaughlin is going to kick that off for us.
Hi, Kim. Thank you for the introduction. My name is Anise Abdullah McLaughlin, and I will be talking about the Hospital Acquired Condition Reduction Program, or HAC-RP. Section 3008 of the Affordable Care Act established HAC-RP. HAC-RP is a Medicare pay-for-performance program that supports CMS's long-standing effort to link Medicare payments to healthcare quality in the inpatient hospital setting to encourage eligible hospitals to reduce HACs. Section 1886P of the Social Security Act established the statutory requirements for the HAC-RP. Effective fiscal year 2014 and beyond, the HAC-RP requires the Secretary to make payment adjustments to applicable hospitals that rank in the top quartile of all subsection D hospitals relative to a national average of HACs acquired during an applicable hospital stay. HACs include a condition identified in subsection 1886D and any other condition determined appropriate by the Secretary. HAC information is required to be posted on the Hospital Compare website per Section 1886P of the Act. There has been a scoring methodology change to the HAC-RP that CMS finalized in the fiscal year 2019 IPPS final rule. That change removed the domains and assigns equal weighting to each measure for which a hospital has a measure beginning with the fiscal year 2020 HAC-RP. The program currently uses the CMS Patient Safety Indicator 90, or CMS PSI 90, and 5 healthcare-associated infections, HAIs, as collected by the CDC, National Healthcare Safety Network, or NHSN. The measures in HAC-RP are categorized under the meaningful measure area of make care safer by reducing harm caused in the delivery of care. The total HAC score is the sum of the equally weighted average of the hospital's measure scores. So the table, there you go. The table below details the number of HAC-RP measures that are prioritized under the quality priorities and meaningful measure areas, which are currently implemented or proposed for HAC-RP. So as you can see, we have effective prevention and treatment, making care safer, which includes the 5 HAIs from the CDC, NHSN, and that CMS PSI 90. We also have communication and care coordination, best practice of healthy living, making care affordable, and patient and family engagement. Next, I'm going to talk about the high priority meaningful measure areas for future measure consideration. For fiscal year 2020 federal rulemaking, CMS may propose the adoption, removal, and/or suspension of measures for fiscal years 2021 and beyond of the HAC-RP. CMS identified the following topic areas as areas within the domain of making care safer for future measure consideration, and they are measures that meet the measurement requirements below that are electronic clinical quality measures, or ECQMs, measures that address adverse drug events during the inpatient stay, measures that address ventilator-associated events, additional surgical site infections locations that are not already covered within an existing measure in the program, outcome risk-adjusted measures that capture outcomes from hospital-acquired conditions and are risk-adjusted to account for patient and/or facility differences, for instance, multiple comorbidities and patient care locations. Measures that address diagnostic errors, such as harm from receiving improper tests or treatment, harm from not receiving proper tests or treatment, harm from failure to diagnose, or harm from improper diagnosis. And measures that address causes of hospital harm, such as an all-cause harm measure or a measure that encompasses multiple harms. And lastly, measures that demonstrate safety and/or high reliability practices and outcomes. Now I'm going to talk about the measure requirement. CMS applies criteria for measures that may be considered for potential adoption in the HAC-RP. At a minimum, the following requirements must be met for consideration. And they are: measures must be identified as a HAC under Section 1886D or be a condition identified by the Secretary. They must address high cost or high volume conditions. They must be easily preventable by using evidence-based guidelines. They must not require additional system infrastructure for data submission and collection. And the measure steward must provide CMS with technical assistance and clarifications on the measure as needed. Thank you, Kim.
Thank you so much. And next, for the Hospital Readmissions Reduction Program, we will have Erin Patton.
Thank you, Kim. Good afternoon. This is Erin Patton, and as Kim mentioned, I'll be speaking about the Hospital Readmissions Reduction Program, or HRRP. HRRP was established under Section 3025 of the Affordable Care Act and codified under Section 1886 of the Social Security Act. HRRP provides an incentive for hospitals to reduce the number of excess readmissions that occur in their setting. A readmission is defined as an admission to an acute care hospital within 30 days of a discharge from the same or another acute care hospital. A hospital's excess readmission ratio measures a hospital's readmission performance compared to the national average for the hospital set of patients with that applicable condition. Planned readmissions are excluded from the excess readmission calculation. Beginning with the fiscal year 2019 program, CMS changed the methodology to calculate the payment adjustment factor in accordance with the 21st Century Cures Act to assess penalties based on a hospital's performance relative to other hospitals treating a similar proportion of Medicare patients who are also eligible for full Medicaid benefits, or dual eligible. Currently in HRRP, there are 6 measures that are listed on the table. They are acute myocardial infarction, heart failure, pneumonia, chronic obstructive pulmonary disease, elective total knee and total hip arthroplasty, and coronary artery bypass graft surgery. All 6 of these measures, as you can see, fall under the communication and care coordination meaningful measure area. For future measure consideration, CMS has also identified promoting effective communication and care coordination as the high priority domain for HRRP. Thank you. I will turn it over to the Hospital Inpatient Quality Reporting Program.
Okay, so the Hospital Inpatient Quality Reporting Program, or also known as IQR, was established by the Medicare Prescription Drug Improvement and Modernization Act of 2003 and expanded by the Deficit Reduction Act of 2005. The program requires that hospitals receiving payment under the Inpatient Prospective Payment System, IPPS, report on a set of clinical quality measures. Performance of quality measures in this program are publicly reported on the CMS Hospital Compare site. And you can skip to the table really quickly, Kim. There are currently 36 measures in the IQR program, including ECQMs that are reported to meet the Medicare and Medicaid Promoting Interoperability program. So there was a 17 in effective prevention and treatment, 7 in making care safer, 6 in communication care coordination, 4 in making care affordable, and 2 in patient and family engagement. The hospital IQR program measures cover a variety of meaningful measure areas, although some gaps and future considerations have been identified. So the following domains have been identified as high priority for future measure consideration. Strengthening person and family engagement as partners in their care, particularly looking at functional outcomes and ensuring that care is personalized and aligned with patient goals. Promoting effective communication and coordination of care, looking at the seamless transfer of health information and measures of EMR safety, such as patient matching and correct identification. Promoting effective prevention and treatment of chronic disease, looking at prevention and treatment of opioid and substance use disorders. And lastly, making care safer by reducing harm caused in the delivery of care, particularly preventable health care harm. And so next, we also have the promoting the Medicare and Medicaid Promoting Interoperability program. And that's also tied in with IQR, so it doesn't have its own, so you can leave the tables up, Kim. Or actually, you can go back to the first description that has both measures. Yes, that. So the American Recovery and Reinvestment Act of 2009 amended Titles 18 and 19 of the Social Security Act to authorize incentive payments to eligible hospitals and critical access hospitals that participate in the Promoting Interoperability program to promote the adoption and meaningful use of certified electronic health record technology, or CERT. Eligible hospitals and critical access hospitals are required to report on ECQMs using CERT in order to qualify for incentive payments under the program. Based on current alignment efforts, hospitals that successfully submit ECQM data to meet the hospital IQR program requirements also fulfill the Medicare and Medicaid Promoting Interoperability program requirement for reporting of ECQMs, which is also why we have them pretty linked here in this document. So the meaningful measure areas and priorities discussed in the IQR program, by extension, are the same for the Medicare and Medicaid Promoting Interoperability program as well. And that wraps it up for me. Thank you.
Thank you so much. And next, I believe we'll have Ronique Evans with the Prospective Payment System, Exempt Cancer Hospitals Quality Reporting.
Good afternoon. My name is Ronique Evans, and I will be providing an overview of the Prospective Payment System Exempt Cancer Hospital Quality Reporting Program. The PCHQR program was established under the Affordable Care Act in 2013. Hospitals in this program are excluded from payment under the Inpatient Prospective Payment System. PCHQR is a voluntary quality reporting program in which data is publicly reported. There are currently 15 measures in the program. These measures cover the effective prevention and treatment, making care safer, communication care coordination, and patient and family engagement, meaningful measure areas. The program's high priority meaningful measure areas for future measure consideration include measures regarding care coordination with other facilities in outpatient settings, such as hospice care, measures of the patient's functional status, quality of life, and end of life, measures related to efficiency, appropriateness, and over or underutilization of cancer treatment modalities, measures related to patient-centered care planning, shared decision-making, and quality of life outcomes, and measures of the patient's end-of-life care according to their preferences. The program is intended to equip consumers with quality of life care information to make informed decisions about healthcare options. It's also intended to encourage hospitals and clinicians to improve the quality of inpatient care provided to Medicare beneficiaries by ensuring that providers are aware of and reporting on best practices. And with that, I will turn it over to my colleague in the End-of-Stage Renal Disease Quality Incentive Program.
All right, thank you so much. And now we're going to have Golden Hort do the End-Stage Renal Disease Quality Incentive Program.
Thanks, Kim. Good afternoon. The ESRD Quality Incentive Program, mandated by the Medicare Improvements for Patients and Providers Act of 2008, is the first value-based purchasing program implemented by CMS. It was first established in 2012 to incentivize the delivery of high-quality care to dialysis patients. The program assesses dialysis facility quality performance and improvement on a variety of quality indicators to assign up to 2% reduction in payment to dialysis facilities for a given payment year. The QIP is mandated to include measures of anemia management, mineral metabolism, dialysis adequacy. Initial program years were limited to measures of hemoglobin and dialysis adequacy, but the program has since expanded to incorporate multiple outcome measures. The program's current outcome measures consider the facility's hospital admissions and readmissions, bloodstream infections, and patient experience of care. Additionally, indicators of the fluid management, medication management, and vascular access have also been included in the program. Most recently, the QIP has adopted a new measure of transplant waitlisting in order to incentivize the dialysis facilities to assist patients in initiating the waitlisting process and maintaining their place on the list. The program's priorities are currently focused in 3 domains of the Meaningful Measures framework. The first is care coordination remains a key quality gap for dialysis patients. The ongoing lack of widespread and effective transmission of health information remains a bar to seamless care for this patient population. Secondly, patient safety is an ongoing concern for a population that is frequently immune compromised and experiences high rates of infections and mortality. Dialysis patients receive multiple prescriptions that must be managed to avoid medication errors and properly manage symptoms. And lastly, patient engagement and experience of care may constitute the most critical element of quality care in dialysis facilities. Every aspect of care provided by the dialysis facility depends in some part on the patient to manage their illness when they are not receiving treatment. Additionally, the dialysis care should ultimately serve the purpose of assisting patients in obtaining the best quality of life possible for them. And we seek to reflect this in quality measurement. Thanks, Kim.
Thank you, Golden. And next we're going to come back to Ada for Hospital Value-Based Purchasing Program.
Okay, thank you. The Hospital Value-Based Purchasing Program, also known as HVBP, was established by the Affordable Care Act. The value-based incentive payments are made each fiscal year to hospitals meeting performance standards established for a performance period using the same hospital quality data reporting infrastructure developed for the Hospital Inpatient Quality Reporting Program. Measures are eligible for adoption under the HVBP program based on several statutory requirements, including specification under the IQR program and posting dates on the Hospital Compare website. Currently, there are 15 measures in the program, 6 in effective prevention and treatment, 7 in making care safer, 1 in making care affordable, and 1 in patient and family engagement. The following domains have been identified as high priority for future measure consideration. Strengthen person and family engagement as partners in their care, looking particularly at functional outcomes, and promoting effective prevention and treatment of chronic disease, specifically prevention and treatment of opioid and substance use disorders, as well as risk-adjusted mortality. And with that, I will turn it over to Vanita.
Good afternoon. This is Vanita Mayor. The ASC Quality Reporting Program was established under the authority provided by Section 109 of the Medicare Improvements and Extension Act. The statute provides the authority for requiring ASCs paid under the ASC fee schedule to report on quality measures. ASCs receive a 2% point payment penalty to their ASCFS annual payment update for not meeting program requirements. Currently, we have measures in the program that fall under 4 healthcare priority areas. They include effective prevention and treatment, making care safer, communication and care coordination, and there's patient and family engagement. The high priority meaningful measure areas for future measure consideration include making care safer, patient and family engagement, best practice of healthy living, effective prevention and treatment, making care affordable, and communication and care coordination. The next program is the Hospital Outpatient Quality Reporting Program. The Outpatient Quality Reporting Program was established by Section 109 of the Tax Relief and Healthcare Act. The program requires Subsection D hospitals providing outpatient services paid under the OPPS to report on quality measures. Hospitals receive a 2 percentage point reduction of their annual payment update under the OPPS system for non-participation in the program. Currently, the program has measures under 5 healthcare priority areas, and those include effective prevention and treatment, making care safer, communication and care coordination, making care affordable, and patient and family engagement. The high priority meaningful measure areas for future measure consideration include making care safer, patient and family engagement, best practices of healthy living, effective prevention and treatment, making care affordable, and communication and care coordination. The Inpatient Psychiatric Facility Quality Reporting Program was established by Section 1886 of the Social Security Act. Under current regulations, the program requires participating inpatient psychiatric facilities to report on quality measures or face a 2 percentage point reduction to their annual update. Currently, the measures include 3 priority areas that they fall under: effective prevention and treatment, making care safer, and communication and care coordination. So the high priority areas for future consideration include strengthened person and family engagement and making care safer by reducing harm caused to the delivery of care.
Good. All right, thank you so much, Vanessa. And last but not least, we have Ronique Evans covering Skilled Nursing Facility and Value-Based Purchasing Program.
Thank you. So the Skilled Nursing Facility Value-Based Purchasing Program, or SNF VBP program, was established under the Protecting Access to Medicare Act of 2014. Every year, CMS publishes a regulation that outlines what is required for the SNF VBP program, and every year SNFs receive incentive payments at the start of each new fiscal year. This program currently reports on one measure, the SNF 30-day all-cost readmission measure, as mandated by legislation. This measure captures the risk-adjusted estimate of the number of unplanned readmissions that occur within 30 days of discharge from acute care. I note that we intend to replace the all-cause readmission measure with an all-condition risk-adjusted, potentially preventable measure as soon as practicable. CMS lacks the authority to implement additional measures beyond the 2 described in the statute. The SNF VBP program focuses on better outcomes and rewards skilled nursing facilities with incentive payments for the quality of care they give to people with Medicare, in particular reducing hospital readmissions. The SNF VBP program moves CMS towards paying providers based on the quality rather than the quantity of care they give to patients. And with that, I will turn it back over to Kim.
Thank you so much to all of our presenters in that section. So I'm going to check in with Patel now to see if we have any questions for our Segment 3 programs.
Yes, Kim, Vince Brown here. We did have one question come in online. Could you comment on how the slides and the Needs and Priorities report will be made available in the video after this meeting?
Sure. So the slides are, very generic. They're just kind of listing out the programs and, and then the forward where we talk about meaningful measures, et cetera. They will be up on the website in the next, probably by late next week at the latest for the Needs and Priorities document. The recording, we do need to closed caption that and put it on YouTube for viewing, so that will be a couple of weeks. And then the Needs and Priorities document itself, I anticipate that being able to be made public by mid-May, so approximately 3-ish weeks. And for everyone on this call, if you put in, which I think you had to, but if you put in your email as you registered for this call, we won't hound you, but we will follow up with a single email once the Needs and Priorities document has been released and is actively published on the CMS.gov website. We will send you an email and let you know that it is up there for viewing. Any other questions through Q&A?
I am not seeing any other questions on the chat or the Q&A function in WebEx, Kim.
All right, so let's go ahead and open up the lines for a moment. Again, please make sure that if you're not actively speaking and asking a question that you are on mute.
Do you want to go on to the next few slides?
Yeah, so why don't we do that? We'll go on to the next few slides. That'll give people about 2-ish minutes to make sure they get their questions in the chat or in the Q&A function. or you can put it in the chat if you can't find the Q&A function as well. But we'll go on to a couple of our next slides and come back and see if there are any questions. So if you want to go ahead, next slide.
Kim, the one I'm looking at describes the next steps, such as the July federal-only stakeholder meeting. Maybe we don't have that visual in the slide deck right at this time.
Sure. So as next steps, and just a couple of things to go ahead and keep in mind. Again, you know, just to kind of drill this date into people's heads, JIRA closes June 3rd. And, you know, I would even say to think of JIRA closing as May 31st, only because June 3rd is, in fact, a Monday. And, you know, it does take some time and a bunch of copying and pasting and things like that to enter your measures into JIRA, and just to make sure that you have, you know, very responsive technical assistance at your fingertips and you have the support that you need. I can't recommend strongly enough that you submit your measures. The earlier the better, of course. We would love to see measures in JIRA now. But, you know, if you really are pressed for time, I would really recommend you start entering them no later than, you know, the week of the 27th. So you have a full week and you, again, kind of can get any of your questions answered promptly versus, you know, trying to enter them over the weekend and not getting as timely of response as you might like. So that's the most important date. After that, we gather all of the measures and we review them internally to see how they fit with our needs and priorities in the various programs, making sure they're fully tested. We put together a draft MUC list and we have it reviewed at the federal-only stakeholders meeting, which is late July this year. You'll notice it's usually in August, but we've kind of moved up the timeline a little bit of the pre-rulemaking cycle to give us some more time on the back end to review the measures and give us a little bit more time for rulemaking, etc. So the federal stakeholders meeting is in July, and then after that it gets reviewed by CMS and HHS and all of our sister agencies there before getting submitted to the MAP no later than December 1st. If you have any questions about the pre-rulemaking process, please, I can't encourage you enough to visit our pre-rulemaking website. You will find so much information there, as well as a JIRA template. Again, if you're in JIRA, you have to submit everything in one fell swoop. You can't save a measure and come back to it. You will lose everything. It's just a function of JIRA. There's nothing we can do about that. But we do have a Word template that you can use to fill it out and, you know, highlight your options and all of that, so that then when you go into JIRA, it's really just copying and pasting, and you can do it in a much more timely fashion. And here's our contact information. Myself, Kim Rawlings, and my colleague, Helen Dollar-Maples, both lead the pre-rulemaking / measures under consideration list. We coordinate this process for all of our programs, and our counterpart at our contractor, Battelle, is Vince Brown, and his contact information is there as well. So with that, I will pause and see if any more questions came in through our Q&A. Have you received?
Have not seen any questions, Kim. Thank you.
All right. Well, with that, we will conclude today's session. Thank you so much for attending. And again, email us if you have any questions. We'll be happy to help. Have a great rest of your day, and we look forward to seeing your measures in JIRA. Thank you.